We stopped last time at, wait lang, mga pumapasok pa pala. So we stopped last time sa regulatory proteins, pero ulitin ko lang just a quick recap on the regulation of complement system. So again, complement system is necessary for the proper defense mechanisms na present sa ating katawan in order for us to fight microbial invasions. However, overactivity of these complement systems can lead to series of devastating reactions which can harm instead of help the cells of the body. So, in this um, in this way, dapat merong mag-regulate sa kanila. So that's why regulation of complement system is present so that these devastating events will be prevented from happening. So yun nga, active tissue could cause tissue damage and have devastating systemic effects if it was allowed to proceed uncontrolled. So yun nga, pag tuloy-tuloy lang yung pag-activate ng complement system natin, then that would mean that yung destruction brought by the complement system will be inevitable. So, yun dapat may regulation talaga. So again, the reasons for regulating complement activity would be first is to prevent the increase of anaphylatoxins. Recap lang sa ating mga pathways. All of them produce anaphylatoxins, particularly yung C3 and C5. So dun sa alternative kasi walang C4. But in classical and lectin, meron silang C4. So, yung particularly yung A fragment nila. Yan. So, all of these three are potent anaphylatoxins that can cause vasodilation the of the veins or of the arteries, basta blood vessel. So, if there are accumulations of these three anaphylatoxic na complements, this would lead, of course, to massive or systemic inflammation, which is not good in the body. Kasi if there's systemic inflammation, then that would mean that the contents inside the blood vessels would leak out. So if the contents inside the blood vessels would leak out, that would mean that there will be a decrease in blood volume, there would be a decrease in blood flow, which would be problematic in delivering the nutrients na present and dapat ma-transport all throughout the body. So if there's the presence of these anaphylatoxins, which will promote vasodilation, then leakage of contents from the blood, and then magkakaroon ng hypovolemia, ng decreased na blood flow, decreased blood volume, which would uh, result to hypoxia and then therefore possibly death. So yun yung one of the severe effects, one of the severe consequences that can happen if there's accumulation of anaphylatoxins. And the regulation of complement system ensures that the increase of anaphylatoxins will be prevented. So yun. Second is to prevent the increase of chemotoxins. Once again, yung nabanggit ko lang na chemotoxin dito or chemoattractant would be your C5A. So C5A is a good chemoattractant which attracts the phagocytes present in the blood, coming from the blood, I should say, towards the site of infection. So it directs the phagocytes towards the site of infection. Yun yung function ni C5A. If there is excess amounts of chemotoxins that will be produced, brought about by the complement activation, what happens there is that too many phagocytes will accumulate in that certain area and parang mag-lead yan into low white blood cell count due to the fact na maraming white blood cells yung pwedeng pumunta dun sa area na yon. And if madaming white blood cells yung pupunta dun sa area na yon, then madedeplete yung body natin ng additional white blood cells to fight for other infections. So yun yung isa sa negative effects pag sobra ang ating chemotoxin. Okay. So it is also stated there that uh, our complement system is really non-specific. It is one of the soluble components of the immune system, which is classified as non-specific. In fact, complement is the major humoral defense mechanism of your natural immunity. So yun. Again, complement system is the major humoral component of the natural immune system. So, given that natural immune system is non-specific by nature, then therefore it is safe to say that complement system is non-specific. Pero itong regulation kasi, it gives the definition of self versus non-self on the complement system. Kasi nga, it helps us, or it helps the individual to prevent the devastating effects of complement system while destroying at the same time yung mga pathogens natin. So it destroys all the pathogens that attempt to invade our body, and at the same time it protects our cells from the negative effects of complement system. Kasi nga non-specific si complement. So it can easily target our cells, it can easily target the harmless na mga substances na present sa ating katawan, which is not good if yun nga nag-activate yung complement dun sa mga harmless cells natin. So pag nag-activate dun, masisira din yung cells inside the body. So yun yung parang function ni mga regulators natin. Okay. So most of these regulatory substances are concentrated on inhibiting or preventing the accumulation of C3b. Kasi once again, I've mentioned this last week, no, na C3 is the converging complement of all the different pathways of complement system. So if you can observe, no, siya yung pinakaunang complement na kung saan common sa kanilang tatlo, sa tatlong pathways natin. So once that C3 is prevented in the first place, then masasabi na natin na hindi maproproceed into activation yung tatlong pathways natin. So yun, most or majority of the regulatory proteins are concentrated on halting accumulation of C3b. So yun yung parang major na focus nila yung C3, particularly your C3b. Okay. So one of the negative effects that complement system can give inside our body is this phenomenon, which what we refer to as bystander lysis. So bystander lysis means that pag for example malapit yung complement activate, for example ito yung bacteria, tapos may mga complement activation dito, complement activation. Then let's say ito yung nearby na parang normal epithelial cell. So let's label this one as your epithelial cell. And nagkataon na dumikit tong bacteria undergoing complement activation dun sa epithelial cell. So that would mean na possibly pwede ding dumikit dito yung mga complement. Once na mag-activate dito sa epithelial cell, sisirain yung epithelial cell. Which is not good kasi epithelial cells are normally part of our body. So, yun yung phenomenon na bystander lysis. Nearby epithelial cells may be lysed with the bacterial cell under complement activation. Of course, with the presence of regulators, this should not happen. In fact, this does not happen regularly. It should not happen. Kasi if it happens, then therefore, yun nga, mag-lead siya into devastating effects inside our body, yung ating complement system. So, the phenomenon being stated there would be your bystander lysis. So, yun. Nearby epithelial cells will be destroyed by microbial cell under complement activation. Okay. So, let's proceed to the regulatory proteins. One of the most important complement regulators that is present inside our body would be your C1 inhibitor. Or to complete the name, C1 esterase inhibitor. Or yung abbreviation niya na C1-INH. So, this regulatory protein, no, this acts, syempre, based pa lang sa pangalan niya, it acts on the C1 subunit. So sometimes the meaning or the function of the substance is already evident in its name. So from the term itself, C1 esterase inhibitor, it inhibits your C1 esterase. Okay? So that basically is the function of your C1 inhibitor. So to specify its function, C1 inhibitor tries to separate, no, tries to remove C1q from C1r and C1s. So para magiging itsura niya is this, ganito. So let's say ito si C1, tapos ito yung ano niya, ito yung binding component niya, ito si C1q, ito si C1r, and ito si C1s. So itong si C1 inhibitor or esterase inhibitor, so let's say ito si C1 inhibitor, no, INH. This one attempts to separate daw yung C1q from C1r and C1s. So, hindi na siya magpro-proceed into activation. Magbabind si C1q dito sa C1 inhibitor. So, masiseparate siya from the C1r and yung C1s. So, question there, ma-activate pa rin ba yung classical pathway natin? So since C1 is part or is unique in the classical pathway, the question there is ma-activate pa ba yung classical pathway natin? Hindi na. Kasi while it is true na pwede pa mag-bind yung C1q sa antibody, kasi di ba? Remember, C1q binds to the Fc portion of antibodies. Pag nag-bind si C1q, pero nakaseparate naman siya kay C1r and kay C1s, edi useless din. Kasi nga, wala naman siyang pag-a-activatean na complement. So, kahit mag-bind pa yung C1q na yan dito sa Fc portion ng antibodies natin, hindi niya ma-activate yung C1r and C1s. Kasi nga, in the first place, hindi siya nakakabit doon sa C1r and C1s. So, that is with the help of your C1 esterase inhibitor. So, yun yung function niya. So, it also affects MBL, mannose binding lectin, in such that it attempts to dissociate MBL from MASP2. So, di ba, paano na ulit yung itsura ng MASP2? Parang ganito ata siya. So, ganito yung itsura. Tapos, ito yung, MASP2 daw, MBL. Ito yung mannose. Ito yung mannose. Tapos meron yung mga parang bukol dito. Kalimutan ko na exact na tsura nila. Pero my point here is that yung C1 inhibitor, this is the MASP2, this is the MBL. It attempts to dissociate MBL from the MASP2. So magkakabit yung MBL dun sa mannose. However, hindi ma-activate yung MASP2 because in the first place, MASP2 is already disconnected from MBL. So, yun yung function ng C1 esterase inhibitor natin, C1-INH. So, one of the clinical correlations, no, in the absence of this regulatory protein is your pain. Or sometimes sapat na yung hay. So, hereditary angioedema. So, parang yun yung isa sa ano niya, yun yung isa sa mga complement or let's say isa dun sa mga regulatory na deficiencies niya, yung pain. So hereditary angioedema. Sometimes pain, no, hereditary angioneuroedema. So yun yung pain. So itong disease na to characterizes yung absence ng C1 inhibitor. So yan. Pain or hay, depende. However, yung ano kasi, the reason why there is the presence of edema in these scenarios is because of the fact that yung C1 inhibitor natin or yung C1 esterase inhibitor natin also is one of the major components na present doon sa ating yung hemostatic pathways. Pero I think that will be discussed later on dun sa hema 2 nyo. So yun yung ano, yun yung parang more on ano kasi siya eh. More on hematologic yung ano niya, yung pathophysiology ng pain. Pero yun nga, one of its deficiencies would lead to pain, yung C1 inhibitor or your C1 esterase inhibitor natin. Can you still follow? Hello?
Yes, sir.
Okay, okay. Sige, let's proceed na sa next. So, what is going to be discussed here next would be the proteins that prevent C3 convertase. So, yun nga, I've mentioned a while back that regulatory proteins are focused in preventing the accumulation of C3b. So, how is C3b formed ba? Siyempre, ano, paano ba nabubuo ang ating C3b? Siyempre, yung cleavage ng C3 into C3a and C3b. And how is C3 cleaved into C3a and C3b? Through the C3 convertase. So, kahit anong pathway man yan, lahat sila meron silang C3 convertase. So, these regulatory proteins now are the ones that are responsible for preventing the formation of C3 convertase. So, yun. First in the list would be your C4 binding protein. Particularly focused to dun sa ating classical and mannose binding lectin. Bakit? Kasi ang ating classical pathway and mannose binding lectin, they are the ones that contain C4. Okay. So from the term itself, C4 binding protein, it binds to the C4 which is present on the microbial surface pag nag-attach siya dun. So pag nag-bind siya dun, then this C4 will be inhibited already. So it will be prevented. So particularly, no, di ba, C4. Tawag doon. Yung si C4, magbabind daw sa kanya si C4 binding protein. So pag nag-bind si C4 kay C4 binding protein, then this C4 will be prevented from being combined with C2A. So yung C4 ngayon, mapipigilan siya nung C4B na mag-bind kay C2A. Okay? So once that C4 is not being able to bind with C2A, then hindi mabubuo ang ating C3 convertase. Kasi 'di ba, recall natin, ano ba ang C3 convertase ng classical and mannose binding lectin? C4b2A. So if this C4 is being prevented from binding with C2A, if C4 is being prevented from binding with C2A, then therefore, walang mabubuo na C3 convertase. So that is for your C4 binding protein. Next one is, this one is cell-bound. So this one binds to your C3b or C4b. So itong substance daw na to, this one is cell-bound. So this is found in the cells or on the surfaces of the cells of the body. And this binds to C3b or C4b. So this one is what we term as complement receptor type 1 or CR1, or yung pag ito-classify natin siya sa clusters of differentiation, CD35. CD stands for clusters of differentiation. So, which is important sa flow cytometry na procedures natin. So, when we hear the word CD, clusters of differentiation, so may mga numbering yan. These are the ones that are primarily detected. So, these are the ones that are primarily detected in flow cytometry procedures. So, flow cytometry, yung mga CD markers natin. So, complement receptor type 1 daw is cell-bound, which means it is present on the surface of the cell. And it binds to C3b or C4b. Therefore, preventing now yung formation ng ating C3 convertase. So, pag for example, nabuo yung ano, for example, hindi siya nakapag-bind kay C4b, kay C3b siya nakapag-bind. So, let's say, 'di ba, si C3b saka lang siya mabubuo pag cleave na siya ng C3 convertase. So, let's say hindi niya na prevent you or hindi nakapag-bind itong CR1 kay C4b. So, si C4b nagtuloy-tuloy siya nakipag-bind with C2a to form your C3 convertase. C3 convertase cleaves your C3 into C3a and C3b. Ngayon, if ito yung nadatnan ng cell, ito yung nadatnan ng cell containing your CR1, the CR1 which is present on the cell will bind now dun sa C3b na nabuo. So, once na nag-bind siya sa C3b, it will not be allowed to bind with C4b2a to form your C5 convertase. So, mga ganung usapan. It can either bind with C3b or it can either bind with C4b. Whatever's the case, it prevents the formation of your C3 convertase. So, yun yung CR1. I'll discuss this later on yung how CR1 works. So, for now, just know na this CR1 will bind to your C3b or C4b to prevent the formation of C3 convertase or C5 convertase. So, yun. Next in the list would also be cell-bound and it binds to C3b. So, this one is what we term as your membrane cofactor protein or MCP or CD46. So, yung C3b, this one can affect either classical, alternative, or MBL. Kasi it binds dun sa C3b eh. Eh, di ba C3b is present in all of those pathways. So, CR1, so nagbabind din siya kay C3b. So, pwede rin siya mag-prevent ng classical, alternative, and MBL. Kasi nga, it binds to C3b. So, yun yung CR1. And last, no, this one binds to C3b and C4b ulit. So, this one actually is a very important regulatory protein because absence of this one would lead to a severe na disease na tinatawag na paroxysmal nocturnal hemoglobinuria. Pero I'll discuss this one later on. Basta, for now, take note that this regulatory protein is important in preventing this kind of disease, paroxysmal nocturnal hemoglobinuria. So this one is your decay accelerating factor, DAF or CD55. So this binds to your C3b and C4b. Okay? So decay accelerating factor. Ano yung common sa kanilang apat? So there is something common among all of them bukod sa it prevents C3 convertase. All of them are cofactors of factor I. Mahalaga tong factor I isa to sa major na regulatory protein of your complement system, factor I. I'll discuss this one. So, factor I, ano nga ba nagagawa ng factor I? Nakikita niyo yung whiteboard?
Opo, kuya.
Opo.
Okay. So, proceed tayo on how factor I mediates or regulates the complement activation system. So, regulation of factor I. Yan. So, let's represent factor I as this kind of drawing. So, pentagon na mayroon siyang ngipin. Yan. So, si factor I yan. Now, if for example, merong nabuong C3b. So, let's say ito yung cell, tapos meron dito yung C3b. Okay? So, si C3b yan. C3b can bind with factor I. So, pag nag-bind siya kay factor I, i-inactivate niya to. It will inactivate your C3b to form, it will inactivate C3b to form your IC3b. So, paano ko na yan? So, pwede siya maging IC3b. Recall natin, di ba pag merong pag small letter I, before dun sa complement name, it means to say that that complement is inactivated. So, factor I will bind with C3b and it will inactivate this complement protein to form now your IC3b. And ang next na fragment dyan is your C3F. Pero si C3F, hindi siya masyadong mahalaga sa discussion. Basta ang point ko lang is factor I will bind with C3b. It will dissociate C3b into IC3b fragment and C3F. C3F. Okay. So, itong si IC3b, it will be further inactivated by factor I. So, factor I will further inactivate IC3b into two separate fragments na naman. One would be your, sorry, mali yung drawing. One would be your C3C. The other will be your C3DG. Minsan tinatawag na rin natin itong C3D. Okay? So, factor I will cleave this C3b to form your C3F. So, ipakita natin yung dissociation niya. C3F and IC3b. IC3b will be further dissociated by factor I to form your C3C and your C3DG. Now, itong C3C and C3DG, these complement fragments are, of course, no longer viable in activating your complement pathway. Kasi nga, na-inactivate na sila ng factor I. So this basically means that your factor I is a potent na inhibitor na ating C3b. So I said a while back that factor I is, yung apat na regulatory proteins which are itong apat, which are responsible for preventing C3 convertase are cofactors of factor I. So factor I may work alone, or factor I will be working together with these four regulatory proteins to prevent yung accumulation ng ating C3b. So, yun. So, si factor I, it can work by itself, no? So, this is one of the many ways on how factor I can inhibit your complement pathway. So, there's another mechanism, no? If you recall, yung diniscuss natin kaninang CR1. So, yung CR1 natin, let's represent another microbial cell. So, sorry. So, ito pala, nandito na pala yung isa sa regulation of factor I. So, dito muna pala. Now, IC3b can further be dissociated by factor I into C3C or C3D. However, IC3b can sometimes remain inside or outside the microbial cell. Nandun mismo sa may microbial cell surface. So there are times na hindi na siya gagalawin ng factor I, pero this IC3b, so let's represent another IC3b. So, di ba nung una, pwede siyang i-cleave ng factor I into C3C or C3DG. Now, let's take another scenario wherein IC3B is not being dissociated by factor I. So, for example, undergoing yung complement activation dito, let's say IC3B, may nabubuo ding IC3B, at the same time may mga na-activate din na separate na complement protein. So, for example, merong separate na C3B dyan, merong separate na C3B dyan, pero may mga nabubuo din na IC3B dito. Now, let's take for example yung complement protein na present sa blood cell natin. So, let's say blood cell yan. Tapos meron siyang CR1, complement receptor 1 na protein. So, yung CR1, it can also bind dun sa IC3B. So, hindi lang siya nagbabind sa C3B. It can also bind with your IC3B. Now, wherein pag nag-bind siya sa IC3B, then this blood cell will already be protected from bystander lysis. Again, yung CR1, di ba, I've mentioned a while back that it is cell-bound. So this cell-bound CR1 can also bind to your IC3B. Pag nag-bind siya sa IC3B, then the blood cell carrying the CR1 regulator protein will be protected from the complement activation that is occurring in this cell. So parang palagay natin, di ba, some IC3B will be formed and some C3B will be formed as well. So parang nag-undergo pa rin yung pathway activations natin. Pero may parang dumaan or may nakasagi na blood cell dito sa microbial cell na to. So yung CR1 na present dito sa blood cell will bind with your IC3B, preventing this blood cell to be susceptible under bystander lysis. So that is how complement receptor 1 works on protecting the cell from bystander lysis. So another way on how factor I is serving as the major regulatory protein, isa sa major regulatory protein natin. So let's take for example another, yung microbial cell. So let's say na-activate siya through classical pathway. So meron dalawang antibody dito. And let's say nag-bind na rin dyan yung C1. C1Q, C1R, C1S. O yan, nag-bind na siya dyan. Let's say nag-bind na siya dyan. So it activates C4 now to become C4A and C4B. So C4B. Tapos yung C4A, di ba, pupunta siya sa circulation to serve as your anaphylatoxin. And here comes C4B, binding to the cell surface of your microbial cell. Next na i-cleave si C2. So si C2A kakabit dyan. And si C2B madidisintegrate. Yan. So this one is your C3 convertase. Now, your C3, let's say si C3 ma-activate nung C4B2A to form C3A and your C3B. C3B will be lodged here, no? Magbabind siya together with your C4B and C2A to form your C5 convertase. So, let's say ganyan na nangyari. Ngayon, I've mentioned a while back that CR1 is able to bind to your C3B. So, hindi lang sa IC3B, kundi pati sa C3B. So, this C3B na present dito sa convertase na to. So, let's say this C3B na present dito sa convertase na to will bind doon sa CR1 na present dito sa macrophage na to. Let's say this cell is a macrophage and it contains CR1 receptor, complement receptor 1 regulator protein. So CR1, magbabind siya dito sa C3B And then this macrophage now will remove yung tawag mo dun? Will remove yung C3b which is found in this cell. This macrophage will attempt to remove not only pala yung C3b but also yung immune adherence natin. So si macrophage kakainin niya to and mapre-prevent ngayon yung formation or mapre-prevent ngayon yung further na activation ng ating classical pathway. So ulitin ko si macrophage here also contains CR1. So pag meron siyang CR1, I've discussed a while back that CR1 binds to your C3b. So pag nag-bind si CR1 kay C3b, pag nag-bind si CR1 kay C3b, then this macrophage will recognize now that there is the presence of your immune adherence. Ito, pag sinabi kasing immune adherence or pag sinabi kasing, sorry, not immune adherence, no, immune complex pala. So, immune complex. If there's the presence of this immune complex, so syempre hindi rin maganda pag hindi rin maganda minsan pag merong presence ng immune complex. Kasi ang disadvantage ng prolonged stay of immune complex inside the body would be the deposition of this immune complex to your cells of the body, promoting ngayon yung type 3 hypersensitivity reaction. Pero later, I'll discuss that one later. So for now, let's take note that once na nag-bind yung CR1 kay C3b, this macrophage will attempt to destroy ngayon yung immune complex ng antibody and antigen. So given that this one is also a bacterial cell, so pwede rin niyang idamay yung buong bacterial cell in its phagocytosis. And the term that we use when we're removing immune complexes in the body is what we term as your immune adherence. So immune adherence is the term na removal ng immune complex which is found in our cells of the body or in sometimes in microbial cells to be engulfed by your macrophage. So CR1 will serve as the receptor, C3b will serve as the ligand, and pag nag-bind yung CR1 kay C3b, this macrophage will be notified or this macrophage will be informed that there's a presence of immune complex present here. Or if not, since hindi lang si C3b yung hindi lang si C3b yung may pakana sa classical pathway, pati rin sa alternative and MBL. So once na nag-bind yung C3b dito, then this macrophage therefore will ignore yung um, will ignore yung cell because basically yung CR1 and yung C3b na present or yung nagko-connect na yun together dun sa macrophage and dun sa cell is only parang functional when it comes to the presence of your immune complexes. So pag wala yan, tapos na-detect na merong C3b, so parang hayaan na lang ni macrophage na mag-occur yung classical pathway or yung complement activation dito sa cell na to without damaging this macrophage itself. Kasi there are times that without this CR1, pwedeng ma-damage ng complement yung macrophage. So, yun yung isa sa mechanisms on how immune adherence works. Primarily on the presence of CR1 which is found on the macrophage. So, pag meron yung macrophage, pag meron yung CR1 sa macrophage, then the immune or the cell which contains the immune complex will be engulfed by this macrophage. So, yun yung parang full na mechanism on how immune adherence works involving your complement. So, there's another one on how factor I, ano mga bang kinalaman ni factor I dito? So, if hindi na recognize ni macrophage yung C3b, then factor I can cleave your C3b to form now your IC3b. And again, di ba ang CR1, pwede rin siya mag-bind kay IC3B. So, pwede rin siya mag-bind kay IC3B, therefore, still promoting your immune adherence na function. So, yun yung isa sa function ni factor I. It binds to your C3b to inactivate it into IC3b. And IC3b, being recognized by the CR1 of your macrophage, will now attempt to engulf the cell containing your immune complex, which removes ngayon yung immune adherence, or which removes ngayon yung immune complex through the process known as immune adherence. So, did you follow? Hello? Narinig ba ako?
Yes, sir, Tom, Doc Tom, yes.
Okay, so no questions po. Okay, so if there's none, then proceed na tayo sa another regulatory mechanism of your up. Ano yun? Yes?
Sir, paulit-ulit yung about sa immune adherence.
Okay, sige. So another function, di ba, ni CR1 is in its participatory function in its immune adherence. So yung basically i-define natin yung immune adherence as removal of your immune complex. So pag merong removal ng immune complex, which ang immune complex kasi it defines the presence of antigen and antibody binding. So if there's the presence of antigen-antibody reaction, so particularly classical pathway lang to involved kasi yun lang yung pathway that requires your antigen-antibody reaction. So immune complex is defined as the presence of antigen and antibody reaction. So ito nandito. Yung nag-bind dun sa antigen. So, di ba, classical pathway proceeds as C1 binds to dun sa Fc portion ng antibodies. Pag nag-bind sila, ma-activate ngayon yung C1R and C1S, forming now your serine protease sa C1S. I-activate niya si C4, magiging C4A, C4B. I-activate niya si C2, magiging C2A, C2B. Magbabind si C2A kay C4B to form your C3 convertase. And si C3, magbabind dun sa C3 convertase to form your C3A and C3B. C3A will proceed to the blood vessel as your anaphylatoxin. C3B will bind together with C4B and C2A. So ngayon, before mag-proceed itong C5 convertase, no? Before mag-proceed itong C5 convertase, let's say na dumaan itong cell na to sa isang macrophage na merong CR1. So yung CR1, mare-recognize na ngayon yung C3B. So yung CR1, mare-recognize niya ngayon yung C3B. Pag yung CR1 na-recognize niya yung C3B, yung macrophage carrying the CR1 will attempt to engulf the cell containing yung immune complex na yan. So again, yung macrophage, yung CR1 ng macrophage will attempt to engulf the cell containing yung immune complex na yan. Kasi the activation of C3b, yung activation or yung presence ng C3b or your IC3b, pag meron yung factor I, states that this cell is undergoing complement activation. So yung cell na yun merong complement activation. And the role of the macrophage is to prevent the damage that it can do to the nearby cells. I-engulf niya yung cell na to. I-engulf niya yung cell na to. But the main purpose of this macrophage right now is to attempt to remove the immune complex. Kasi pag mayroong immune complex na present dito sa cell na to, pag merong immune complex na present dito sa cell na to, it can activate more complement through C1. Madaming C1 ang ma-attract dun sa immune complex and pwede niyang idamay yung nearby cells that that should not be activated or that should not undergo complement activation. So pag dumaan yung cell na to sa may macrophage na part, so containing your CR1, CR1 ngayon will bind dun sa C3b kapag meron na siya, and this macrophage, this CR1 will send signal to the macrophage to engulf the whole cell containing your immune complex. So that process is what we term as your immune adherence. So primarily this whole scenario occurs in the spleen. Kasi there are abundance of splenic macrophages present inside the spleen which are responsible for removing immune complexes which are normally found or which are not normally found inside the body if nagtagal yung stay ng immune complex. The more na magtagal yung immune complex sa loob ng katawan, the more na mag-a-attract yan ng C1, the more complement will be activated and nearby cells will be affected as well. So para ma-prevent yung complements or subsequent complement activations due to the simple presence of your immune complex, dapat ma-engulf na or dapat ma-clear na siya inside the body through your immune adherence. So, clear na po ba yun?
Sir, Francisco po.
Yes?
Sir, in short po, ay yung sa pagkakaintindi ko, sir, yung immune adherence is yung ability nung cell or nung macrophage to bind dun sa complement activated particles, parang ganun. Ulit.
Primarily your C3b. Kasi 'di ba si R1 yung CR1 yung receptor niya.
Parang yung immune adherence po, sir, is ability ng macrophage to bind dun sa complement coated na cell. Parang ganun po yung immune adherence, sir.
Oo, parang ganun na rin siya. Particularly through the presence of your immune complex. Kasi ang main role ng immune adherence is to remove the cell containing yung immune complex through binding now dun sa classical pathway na activated na C3b. So yun yung function ng immune adherence diyan.
Thank you po, sir.
Okay. So yun. Again, yung C3b, 'di ba, it can also be parang pwede siyang mag-accumulate doon sa mga other pathways such as alternative or your MBL pathway. Pero yung CR1 kasi ng macrophage is primarily speaking more or is primarily focusing more on classical pathway na C3b. Kasi I've mentioned a while back, pag merong CR1 na present dito sa sa macrophage na nag-bind sa C3b pero walang immune complex, yung macrophage ngayon will have other receptors that will allow it to determine if i-engulf niya yung cell or not. So ang finokus ko lang na receptor dito is your CR1. But take note that macrophage has a lot of receptors which can inform the macrophage whether to engulf the cell or not. So parang ang main focus ko lang is yung CR1 that focuses now on the classical pathway activated C3b. Kasi the main purpose of CR1 in this macrophage right now is to remove the immune complex na present, which is itong antigen-antibody reaction, through immune adherence. So yun yung basic function ni macrophage dito. So that's for your immune adherence na process. Okay, there's another one na parang ginagawa ni factor I. So yung factor I dito, again, it can inactivate C3b into IC3b. Na this can also bind dun sa CR1 ng macrophage. So yun. Another last na mechanism ng factor I natin. So factor I. So again, ito yung itsura niya. Is its help in preventing your alternative pathway. So in this case, no, in this case, yung activation ng ating alternative. So C3 will be naturally hydrolyzed through C3 takeover. Di ba? Maalala nyo? C3 takeover yung recognition process ng ating alternative. So C3b, so let's say mabubuo si C3b dito. And si C3b magbabind dyan si factor B. Naturally, di ba? Magbabind si factor B dyan. So yan. Ito BB, B small b. So ngayon, there's another regulatory protein that competes with factor B in binding to your C3b. And that is your factor H. So let's say ganito yung tsura ni factor H. So factor H will compete with factor B in binding with your C3b. Pag pag nauna si factor H na mag-bind kaysa kay factor B, then may inactivate or mapre-prevent na yung activation ng ating C3 convertase, C3b-BB. Okay? So again, if factor H is able to bind to your C3b, then factor BB will not activate or will not bind anymore with C3b, knowing na meron na nakabind na factor H sa kanya. So yan. So factor H, siya yung nagpre-prevent ngayon sa factor B, sa factor BB to bind with your C3b. So that's one of the mechanisms on how factor H works. And factor H is a cofactor of factor I. So pag nakita niyo factor I na may nakabind na factor H dito sa C3b, then i-cleave ngayon ni factor I si C3b to form your IC3b and yung C3F. So, yan. So, magbabind lang si factor H dyan and magre-recognize siya ni factor I. Then, factor I will be able to cleave C3b into C3F and IC3b. Another parang scenario dyan, if C3b, so for example si C3b, no, nakapag-bind siya kay factor BB. So, yan. Nakapag-bind siya kay factor BB. Yung B fragment ng factor B. Okay. So this one is yung C3 convertase, di ba? C3b, BB. And nagkataon na merong C3b na bago, either from your hydrolysis of yung dumadaan na C3 or pwede rin makleave nitong C3 convertase. So si C3b, magbabind siya dito. C3b. So C3b, BB3b. That is your C5 convertase, di ba? Ngayon, pwede pa rin siya ma-inactivate ng factor H. Itong C5 convertase na to. Pwede pa rin siya ma-inactivate ng factor H. So, pwedeng dumikit dyan si factor H. Kasi since factor H is still able to bind with factor 3b. With your C3b. Tapos, pwede rin siyang ma-recognize ni factor I and pwede rin siyang ma-dissociate. Dissociate yung 3b into IC3b, and C3F. So, yun yung another mechanism ni factor I in inactivating now your C3b into IC3b. So, yan lang yung three mechanisms ni factor I in regulating the activation of your C3b. So, are there any question? So, if wala, proceed na tayo dun sa sa lecture. So, yan. Take note also that this decay accelerating factor is more specific to cell-bound C3b and C4b. So, where there are times that these regulator proteins nakakapag-bind sila dun sa soluble or yung freely floating na mga C3b and C4b sa plasma. Pero this decay accelerating factor is more activated or more specific to your cell-bound na C3b and C4b. So, yan yung meron kay DAF. So, let's proceed to the next. S protein or your vitronectin. This binds to your C5b67. So, parang more focused siya ngayon on the prevention of MAC formation. So, it prevents MAC formation. So, MAC formation, si S protein or yung vitronectin na tinatawag. So this prevents them to submerge or insert into the cell surface, itong S protein or your vitronectin. This prevents the C5b, 6, and 7 to submerge or insert to the cell surface. So clusterin, medyo hindi siya mahalagang regulatory protein, but it also has the same action with your vitronectin or your S protein, which binds to your C5b6 or 7. So this one, again, this is another important regulatory protein kasi this one, including yung decay accelerating factor, the deficiency of these regulatory proteins will lead to your PNH or your paroxysmal nocturnal hemoglobinuria. So this one is what we term as your membrane inhibitor of reactive lysis. Okay, so yan. Homologous restriction factor is another regulatory protein which binds to C9. Take note also na yung C9, di ba, maalala natin dati, last week, diniscuss ko to na yung C9, it is not really necessary to complete the MAC formation kasi yung C5b, 6, 7, 8 is already enough to cause or to perforate yung ating cell membrane, to cause or to form holes inside the cell membrane to leak the contents. Pero in a slow process na lang. The purpose of C9 is to accelerate the process ng formation ng holes ng cell membrane. So in order to slow down yung perforation, C9 should not be able to bind dito sa complex na to. C9 should not be able to bind dito sa complex na to. And the one that is responsible for preventing C9 binding to this C5b678 is your homologous restriction factor. So yun. This one is another regulatory complement protein na na-discuss ko kanina. So this one is your factor H, which is primarily the regulator of alternative pathway. Kasi nga, di ba, C3b, BB, pwede pa siyang makapag-bind dun sa C3b in competition with your factor B. So, yun, factor H. So, I've also discussed this a while back. Factor H is a cofactor of factor I. And paki-correct yung bullet, actually ang tinutukoy dito is yung factor H, not your factor I. So this competes with factor B in binding with C3b. So yung diniscuss ko kanina. Okay? So we also have your regulators for anaphylatoxins, which are not really important in complement system. Pero it's nice to know that there are also these regulatory mechanisms to prevent the accumulation of your anaphylatoxins. First is your anaphylatoxin inhibitor. From the name itself, it is a regulatory substance that binds to your anaphylatoxin complements such as your C4a, C3a, and C5a, thereby preventing them in causing inflammation. Another same function lang siya, carboxypeptidase. It cleaves naman yung C4a, C3a, and C5a. Carboxypeptidase. So, pag sinabing peptidase, it cleaves yung peptide bond doon sa uh, anaphylatoxins natin, C3A, C4A, C5A. Kasi, 'di ba complement are proteins. So, complements are proteins. And these proteins contain peptide bonds. So, since protein din 'tong mga 'to, coming from dun sa actual na substance nila, which is yung C3, C4, and C5, which are also proteins, then itong enzyme na 'to, it cleaves yung peptide bonds that occur in these three anaphylatoxins natin. So, yan yung function ni carboxypeptidase N. Let's also take note that the most potent complement anaphylatoxin, and at the same time, it also functions as a chemoattractant. It's no other than your C5A, to be followed by C3A and C4A. So, yun yung most potent complement na anaphylatoxin is your C5A. Then next is your C3, then C4A. Okay. So, I have here a table. Pinakamahalagang i-memorize nyo dito is yung CR1, which has the function of your immune adherence. So, CR1 has a ligand ng C3b. So, na-discuss ko na to kanina. IC3b and your C4b. There's another important fact here that I'd like to discuss, no. Pero hindi siya need na i-focus dito sa complement. Yung CD18 saka CD11B. Pati itong CD11C dito sa CR3 and CR4. This primarily is present doon sa ating mga doon sa ating mga white blood cells and endothelial cells. So, yung how exactly does a phagocyte migrate from inside the blood vessel towards the tissue space. So, yung process na yun is yung extravasation. Diapedesis is only a part of your extravasation. Di ba, yung diapedesis yung madalas nating naririnig na migration ng migration ng WBC from the blood vessel towards your tissue space. So, diapedesis is under your extravasation. There are steps na i-consider dun sa extravasation. First is yung rolling. So, yung white blood cell will roll dun sa walls ng blood vessel. Your white blood cell, your phagocyte will roll dun sa wall of the blood vessel. So, this is followed by your adhesion. So, ito na yung mga CD11B and your CD18. Then, after adhesion, then that comes your diapedesis. So, parang ganito siya. Ito yung endothelial cells. Ito yung white blood cell. So, magro-roll lang siya dyan. Hanggang sa mag-bind na siya sa mga certain receptors which will allow the phagocyte to stop dito sa endothelial cell. So, pag nag-stop siya dyan, then parang yung receptor na nakabind dito sa white blood cell will allow this white blood cell to parang perform an amoeboid motion dito sa spaces between blood vessel wall. Then, lalabas na siya. So, ito yung diapedesis. Ito yung adhesion. Then, yung rolling yung first na step. So, rolling yung first na step. Yung roll kasi, required siya para yung hindi madala sa blood flow yung white blood cell. White blood cell needs to go out. But it cannot go out easily if it will be allowed na maitangay siya nung blood sa blood flow. So, yun. Rolling is needed. Then, adhesion, para mag-stop yung rolling. And then, diapedesis. So, magro-roll out siya, ma-migrate na siya from the blood vessel towards your tissue space. So, that's your diapedesis. Pero for complement, for our topic today, complement, ang mahalaga is yung CR1. Also take note yung CR2, which is your CD21. CD21, dapat hindi nyo na makalimutan to. CD21 is a CD marker of your B cell. So, yan, CD21. So, we're done with the regulatory proteins. No? Let's proceed dun sa diseases associated with your complement system. So, during inflammation, we have these substances termed as your acute phase reactants. So we have these substances called your acute phase reactants. These acute phase reactants, these substances, or basically they are proteins that are involved in inflammatory processes. There are two types of acute phase reactants kasi. We have your positive APRs and your negative APRs. So we have your positive acute phase reactants and we have also your negative acute phase reactants. Majority of the plasma proteins, majority na ating plasma proteins sa katawan is positive APRs, except for 3. There are 3 proteins which are considered as negative. Pero before that, ano nga ba ibig sabihin ng positive APR? Positive acute phase reactants, these are substances that increase in the presence of inflammation. Positive. So, parang ganun nyo na lang siyang isipin. Positive acute phase reactants are substances that increase in the presence of inflammation. Whereas your negative acute phase reactants, kabaliktaran. Magde-decrease sila in the presence of inflammation. So, na-discuss ko a while back that majority of your plasma proteins are positive acute phase reactants, except for 3. So, 3. Yung isa, hindi siya matatagpuan sa plasma. More on CSF siya. Pero it's good to know that this one also is a negative acute phase reactant. First, we have your albumin. So, in the presence of inflammation, bababa ang ating albumin levels. Second is your transferrin. Paki-memorize kasi high yield question to sa board exam. So, first is your albumin, second is your transferrin. And another negative acute phase reactant, which is primarily present in CSF, is your prealbumin. So, prealbumin. Prealbumin is also termed as transthyretin. Transthyretin. So, yan. Albumin, transferrin, and prealbumin or transthyretin. So, yun. Majority are positive acute phase reactants. That includes your complement proteins. So, take note, lahat po ng ating complement proteins are positive acute phase reactants. Okay? So, lahat po ng ating complement proteins are positive acute phase reactants, which increase in the presence of your inflammation. So, yun. Diseases associated with complement system are more inclined to deficiency of complement rather than excess. So, yung mga diseases daw involving our complement system are primarily due to the deficiency of complement proteins. Kulang yung concentration rather than excess. So yun yung main parang mechanism ng ating diseases associated with complement system. So there are a lot of reasons for the decrease in concentration. First is, let's take note na majority of complement proteins, di ba? Na-discuss ko sa una na they are produced primarily by the liver. So if there's the presence of liver disease, do not expect na makakaproduce siya normally ng complement proteins kasi affected siya eh. Affected yung liver. So, in the presence of liver diseases, the complement protein synthesis will be affected. So, yun. One reason is liver disease. Second is if yung individual undergoes a recent na parang infection. So, let's say kagagaling lang natin sa isang bacterial infection na sakit. So, naka-recover tayo. During the first few part ng recovery natin from the infection, activated majority ng complement, na-exhaust lahat ng sources natin ng complement. So, in this case, mababa yung complement proteins natin sa katawan. Pero syempre, napapalitan naman sila. Pero, yun nga, pag mayroong recent na activation ng complement, since they are consumed, then in the first or in the early phases ng ating recovery, mababa yung concentration ng complement system. Another is yung current consumption. So, hindi lang recent hindi lang right after. Even the fact that during complement activation, nauubos sila, nababawasan yung concentration nila during complement activation. So, not only recent, but also during complement activation. So, there are times naman na genetic deficiency occurs. So, there are mutations in the genes of a certain individual leading to the defect in synthesis of complement proteins. Kasi 'di ba, if ma-recall nyo sa cytogenetics natin dati, the first or the central dogma of molecular biology is your DNA replication, transcription, translation. So, transcription, translation, basically proteins yung nabubuo dyan. Amino acids, order of amino acid chain. Then, eventually, magiging protein yan. So, if there's a problem in the genes of the patient, then therefore, affected din yung production ng ating complement proteins. So, one of the most common deficiency in complement system would be your C2. Ito yung most common. This is the one that usually occurs in an individual suffering from a disease associated with complement system. But the most severe is your C3. C2 deficiency is the most common. C3 deficiency is the most severe. Again, bakit most severe ang C3 deficiency? Kasi nga, di ba, first reason is that it is the most abundant protein, complement protein inside the body. Pag nagkaroon pa ng deficiency dyan sa complement na yan, dyan sa C3 na yan, then masyadong severe mamaya yung effects ng infection, which requires this complement protein for infection to be reduced or for the infection to be treated. Another reason is that the deficiency of C3 convertase, C3 convertase daw. The deficiency of C3 complement pala, I should say. The deficiency of C3 complement is most severe because of the fact that this one is the converging complement of all the three pathways. Pag nagkaroon ng deficiency ng C3, do you even expect na ma-activate ng complete ang ating complement? No. So, parang parang isa siya sa major na na kailangan na complement sa ating katawan. So, deficiency of C3 is most severe. So, bukod sa genetic deficiency of complement, we also have the genetic deficiency of regulatory proteins. So, if regulators naman ang deficient, then complement activation will continue hanggang sa pati yung katawan natin nasira. So, yun. The genetic deficiency of regulatory proteins. Also take note yung C3 and also C4. These are measured by your radioimmunoassay. So, radioimmunoassay. So, yung basic na mechanism ng ating radioimmunoassay, radio-labeled antibody. So, may tag ng antibody dito, may tag ng radio substance dito sa antibody na to. Pag nag-bind siya sa antigen, mag-i-increase ngayon yung radioactivity ng substance. So, once na nag-bind yung radio-labeled na antibody dun sa antigen, then tataas yung radioactivity ng radio-labeled substance na or yung substance na yan. So, yun yung radioimmunoassay. So, what about the clinical manifestations ng ating diseases? No? So, what about yung clinical manifestations nila? In early cases, recurrent pyogenic infections. Again, early clinical manifestations would result to your recurrent pyogenic infections. Bakit yung recurrent pyogenic infections? First, 'di ba, yung pyogenic infections natin. Wait lang. Yung recurrent pyogenic infections natin, this is mainly affecting yung ating factor H or factor I. So yung factor H or factor I, 'di ba sila yung main na regulatory proteins, 'di ba? Nung particularly factor H is regulatory protein of your alternative pathway. Factor I is a major regulatory protein. So in the presence of recurrent pyogenic or in the presence of S pyogenes, so 'di ba maalala natin meron siyang protein M protein pala. Itong M protein kasi na to, it resembles factor H or factor I. So itong M protein na to, this one binds dun sa complement system natin para mapigilan yung pag-activate ngayon ng complements natin. So that is how M protein prevents yung ating factor H. So ngayon, tawag mo doon? Ngayon, without this factor H or factor I, na all the more na mas makatulong kay S. pyogenes to proceed to infection. So, yung recurrent pyogenic infections will occur in the deficiency of factor H or factor I. So, yun. Next, if there's the presence of immune complex, no? If there's the presence of immune complex and nagkataon na wala tayong CR1, di ba yung CR1 yung receptor ng macrophage kanina. Pag wala tayong CR1, pag deficient tayo sa CR1, yung immune complex will deposit into our tissues. So, the immune complex, antibody antigen, will deposit in our tissues, causing yung tinatawag nating immune complex deposition diseases. Next, you also have autoimmune diseases naman as your early clinical manifestation. So, yung early clinical manifestations associated dun sa diseases ng complement system involves your recurrent pyogenic infections, immune complex deposition diseases, and autoimmune diseases. So, yan. Next, for the late na clinical manifestation, this involves your recurrent disseminated Neisseria infection. So, bakit nga ba si Neisseria? Ano meron kayo Neisseria? Particularly your Neisseria meningitidis, no? So, primarily your Neisseria meningitidis. Ang meron kasi kay Neisseria meningitidis is that it prevents or parang it is susceptible to the formation of MAC. So formation of MAC, once that MAC is formed, susceptible si N meningitidis dun. Now, if there's the absence of MAC, if there's the deficiency of complement proteins involving your MAC, then yun nga, mag-occur itong recurrent disseminated Neisseria infection in the late phases of your complement system. When we're speaking of early and late, ang tinutukoy ko dito yung late portion ng pathway and yung early portion ng pathway. So yun yung tinutukoy ko dyan when we speak of your early and late clinical manifestations. Kasi di ba ang formation of MAC occurs in the late phases of your complement activation system or your complement pathway activation, I should say. So, yun. Autoimmune disease, bakit nga ba si autoimmune disease? Kasi pwedeng yung auto-antibody natin mag-bind sa self-antigen natin. So, self-antigen. And pwede siyang mag-activate ng complement or C1q. Pwede siya mag-activate ng classical complement, which can destroy the cell, of course. So, in the presence of autoimmune diseases, yun. Auto-antibody will bind to the self-antigen, causing the complement activation to proceed and pwedeng masira yung sarili nating cell. So, this occurs in the early phase kasi nga, yun, immune complex, ito yung pinakaunang nangyayari bago mag-bind sa C1q. So, yun. So next, most of your genetic deficiencies are generally autosomal recessive, except for your proper gene. So proper gene is X-linked. X-linked siya na, X-linked siya na pattern of inheritance. So this usually occurs more on males than females. So yung proper gene natin. Next, your MBL, which is autosomal dominant. Pag sinabi kasing autosomal recessive, you need at least 2 copies of that gene for you to express the disease, for you to express the genetic deficiency. Pero pag autosomal dominant, you only need 1 copy of that genetic abnormality for you to express the disease. So, yun. If ma-recall nyo sa cytogen. Next, we also have your C1 esterase inhibitor or your C1-INH. It can be acquired. It can also be autosomal dominant. So, yung HAIN. Autosomal dominant siya in characteristic. And lastly, pwede rin yung ating decay accelerating factor or your CD59. Pwede rin yung homologous restriction factor. Yan. Acquired siya. Hindi siya genetic abnormality. Acquired. So, X-linked, si proper gene. Mannose binding lectin is autosomal dominant. C1-INH is autosomal dominant or acquired, and yung DAF natin is also acquired. The rest are autosomal recessive in origin. Okay? So let's proceed to the actual diseases na nabanggit din dito. So first we have your paroxysmal nocturnal hemoglobinuria. So how does paroxysmal nocturnal hemoglobinuria happens nga ba? 'Di ba nabanggit natin kanina yung there is the problem with decay accelerating factor and your membrane inhibitor of reactive lysis. Okay? So may problema daw kay DAF or kay MERN. So ano nga ba yung exact na problem here? In normal individuals, so normal muna tayo, normal. Normal individuals, dun sa stem cell nila, they contain your pig A gene. So, ano nga ba yung ibig sabihin ng pig A? Phosphatidyl inositol. So, phosphatidyl I inositol glycan A. Phosphatidyl inositol glycan A. Yung ibig sabihin ng pig A gene. So, this pig A gene results in the formation of GPI anchor. So, ang protein na naproproduce daw from this gene is your GPI anchor. So, ano naman ibig sabihin nitong GPI anchor? This is your glycosyl phosphatidyl inositol. This is termed as your glycosyl phosphatidyl inositol. So, GPI anchor. Ngayon, ang magiging itsura niya is yung GPI anchor, madedevelop siya dun sa stem cell. This stem cell, I'm referring to this one as yung stem cell na magpo-proceed into your mga blood cells natin. So, let's say, focus tayo kay red blood cell. RBC. Okay. RBC. Tapos, dun sa RBC, meron na siya mga GPI anchor. So, let's say, ito yung itsura ng GPI anchor. Yan. So, yung GPI anchor, this one binds to yung DAF na present sa ating body. So, yung GPI anchor, this one will bind to DAF. So, mag-run through tayo saglit. In normal individuals, yung stem cell nila produces pig A gene, your phosphatidyl inositol glycan gene, which will produce yung gene product na tinatawag nating GPI anchor. So, GPI anchor is yung glycosyl phosphatidyl inositol. So, yung GPI anchor, ma-express siya ngayon sa mga mature na RBC. So, ito mga black squares dito or red squares na merong red na color. Yung GPI anchor, this one will bind doon sa DAF na present sa ating katawan. Magbabind siya sa DAF. In the presence of DAF, pati na rin sa MERL, actually magbabind din siya sa MERL. So, MERL. In the presence of DAF and in the presence of MERL, for example, yung bacterial cell dito, undergoing complement activation, will never harm yung RBC. This will protect the RBC from the bystander lysis. So, pag may nearby complement na mag-a-attach dyan, or may nearby na complement na didikit dun sa RBC, yung DAF, it prevents ngayon yung DAF, it prevents the attachment of C3b dito sa RBC. Kasi 'di ba, DAF binds to your C3b pag cell bound siya. DAF will prevent the attachment of C3b sa RBC. So therefore, this RBC is protected. Protektado yung RBC na yan from bystander lysis. So what happens in the patients with PNH, paroxysmal nocturnal hemoglobinuria? Ano nga ba mangyayari sa kanila? Wait lang. So in patients with paroxysmal nocturnal hemoglobinuria, their stem cell do not contain pig A gene. So pag wala silang pig A gene, then therefore wala ma-produce na GPI anchor. If there will be no GPI anchor na ma-produce, yung RBC ngayon cannot be able to bind dun sa DAF and dun sa MERL. So pag wala yung attachment ng DAF and MERL sa RBC, this RBC, do you think it's still protected from bystander lysis? No. So, for example, RC1 daw, complement activation dito sa bacterial cell na to, kapag dumikit siya kay RBC, pwede mag-lyse yung RBC natin. Magla-lyse yan kasi there's absence of yung receptor that will bind to your DAF and your MERL, yung GPI anchor natin. Walang GPI anchor because there is a defect or there is the absence of your pig aging. So hindi maproprotektahan yung RBC from complement activation. Therefore, magla-lyse siya sa loob ng katawan. So that is how PNH works. So this RBC now will be susceptible dun sa tinatawag nating bystander lysis. Bystander lysis. Yan. Okay, there's one thing na tinuro sa amin nung college. So, there's one thing that is being taught to us in college. Kasi ito yung official name ng disease, paroxysmal nocturnal hemoglobinuria. Ito yung official name nung disease. Pero based from the mechanism on how this disease works, this should be named daw as chronic nocturnal hemosideриnuria. Pero mag-focus na lang kayo sa PNH, pero parang ano kasi to eh. It makes sense kasi din to. Chronic nocturnal hemosideриnuria. So, bakit nga ba chronic nocturnal hemosideриnuria? When we say paroxysmal, paroxysm, it means intermittent. So, on-off, mga ganun bagay. So, this can happen now, this will not happen later, and this can still happen later on. So, intermittent, on. However, the mechanism of the disease more likely describes this one as something chronic. Tuloy-tuloy na nangyayari, chronic, instead of intermittent. So, parang hindi daw proper na paroxysmal yung tamang term sa PNH. So, it should be chronic daw. Nocturnal, it's defined to be termed as nocturnal, which means that this usually occurs at night. So, this usually occurs at night. So, parang sinabi niya dito, kaya daw nocturnal, kasi there will be more bystander lysis that occur in the night than during the day. So, yun daw. Pero it still happens all the time. It happens all throughout the day. Pero more lysis will occur at night compared sa day. So, yun yung medyo hindi rin maganda yung nocturnal. Pero anyway, kasi parang ang tinutukoy niya dito ay mas active daw yung lysis ng cells natin at night compared sa day. So, bakit nga ba mas active ang lysis sa gabi? Kasi daw ang sinabi dito, complement is more active at night, especially when sleeping. Bakit? During sleeping, so medyo may kinalaman to sa acid-base balance, no? So, during sleeping kasi, slower breathing ang nangyayari. Slower breathing. So, when we speak of slower breathing, syempre decrease yung ang ating respiration. Pag decrease yung respiration, less na oxygen measured through PO2 will be able to enter inside the body, and there will be more PCO2 that occurs or that is present inside the body. Slower breathing means that hindi mo masyadong na-exhale yung carbon dioxide na excess sa ating katawan. So, usually nagre-retain yung carbon dioxide sa katawan. And if we all know that PCO2 contributes to the acidity of the body. So, increased PCO2 levels will lead to acidic pH of the body. So, pag acidic yung pH ng body, dyan daw mas active ang complement. Mas active daw siya sa acidic na pH compared sa neutral or alkaline na pH. It will be prone to activation in an acidic medium compared to an alkaline medium. So again, bakit daw mas active ang complement sa gabi? Kasi during sleeping hours, mabagal ang breathing process natin. Less carbon dioxide will be expelled inside the body, so ma-retain sila sa loob ng katawan, increased concentration. Then this increased concentration will now result to an acidic na surrounding ng inside the body. And acidic pH daw or low levels of pH will lead to increased tendency of complement activation. So yun yung reason kung bakit daw tinawag na nocturnal. Next, hemoglobinuria is not really the case, no? It's more on hemosideриnuria. Kasi yung lysis ng RBCs natin, parang na-store muna siya as hemosiderin. Na-store siya as hemosiderin, yung mga hemoglobin na na-liberate from the hemolysis of RBC. Na-store daw siya as hemosiderin sa renal tubular epithelial cells natin sa kidneys. So, na-expel natin siya as hemosiderin instead of hemoglobin. Since hemoglobin is toxic sa ating RTE, so yung hemoglobin magiging hemosiderin siya. Yung hemosiderin ngayon, yun na-excrete sa urine. And it should be termed as hemosideриnuria instead of hemoglobinuria. So, ganun daw dapat. Pero, di officially accepted yung PNH as its official na name ng disease. Clear ba yung PNH, guys? Hello? Are you still there? Okay. Sige. So, ganun yung mechanism ng PNH. It does not primarily speaks of the deficiency or the actual deficiency ng DAF and MERL. Kaya lang sila nagbumukhang deficient kasi mas effective sila sa cell-bound na surfaces eh. Given na wala sila mapagkapitan na cell-bound na cell due to the absence of GPI anchor, doon sila nagbumukhang deficient, yung DAF and MERL. So technically speaking, they are usually not deficient, but given that their function is more focused when they are bound to a cell, then parang masasabi na rin nating deficient sila. But the actual deficiency that occurs here in these patients is the GPI anchor. So there's a defect. There's a defect in the production of your GPI anchor. So leading to the deficiency in DAF and MERL. So technically, they are not the ones that are really deficient. Ang deficient is yung GPI anchor. The reason why we classify them as complement deficiency is because of their inability or because of their inability to perform their function due to the fact that they cannot bind to a cell surface. So yun yung reason kung bakit. They are technically deficient in DAF or MERL. So CD55 or CD59. So walang GPI anchor na kung saan pwede mag-attach tong dalawang to, then the RBCs of that individual will be susceptible to bystander lysis. Kaya kung papansin niyo na encounter niyo to sa HEMA, kasi PNH is classified as hemolytic anemia. Yan. So PNH is classified as hemolytic anemia. GPI anchor yung wala. So hindi magagampanan na mabuti yun ng DAF and MERL yung function nila because they are more inclined to cell-bound surfaces rather than soluble substances. So therefore, PNH will occur. So yun nga na discuss ko kanina, these RBCs are now prone to bystander lysis. So another disease na di-discuss natin ngayon, na ano ko na to, na discuss ko na to a while back, hereditary angioneurotic edema. So hereditary angioedema is fine, hereditary angioneurotic edema is also fine. But the main function or the main problem here is the deficiency of your C1 esterase inhibitor. Pag wala si C1 esterase inhibitor, C1 will just be activated under the presence of your immune complex, then classical pathway will continue. And pwede siyang occur, pwede siyang mag-cause ng damage sa cells natin. The reason, parang nabasa ko lang siya, nabasa ko lang siya ng konti. Pero the reason daw kung bakit may edema is because of the fact that dun daw sa blood vessel walls natin. So, di ba blood vessel wall yung nagseparate sa blood and dun sa tissue spaces natin. The reason why there is edema is because of the fact that absence daw of the C1 esterase inhibitor will lead to parang complement activation. Pag for example, merong immune complex. So, let's say merong immune complex na nag-bind kunwari dyan, or let's say nag-bind sa nearby na cell. Let's say nag-bind sa nearby na cell. Sabihin natin sa labas sa tissue space. So, cell to, may nag-bind na antibody dyan, nag-activate yung C1, nagbuo yung C3b, tapos dumikit siya dito sa endothelial cell na to nang walang C1 esterase inhibitor. Malalyze yung endothelial cell, magkakaroon ng leakage from the blood towards the tissue space. Kaya merong edema. Hereditary angioedema means to say that the blood vessels are the ones affected. From the term angio, dapat ang iisipin nyo na dyan is blood vessel siya, yung affected. And edema will occur. So in some cases daw, the nervous system, the neurons of our body will also be affected by this complement-mediated process. So, ang nangyayari dyan is that pwede din daw masira yung nerves natin, resulting to tingling sensation sa periphery natin. Tingling sensation or pain, ganun. Kaya nag-o-occur yung hereditary angioneurotic edema. So, yun. Deficiency of C1 esterase inhibitor. So, there is a deficiency in C1 esterase inhibitor. So, it has two types daw. Type 1 is quantitative. So, deficient yung C1 esterase. Yun lang ibig niya sabihin. Kulang sa bilang ang C1 esterase inhibitor. Quantitative defect yan. So, it does not produce enough or none at all. In this case, C1q is normal. So, hindi naman siya yung affected. Hindi naman si C1 yung affected. Si C1q yung affected. So, si C1q daw. Si C1 esterase inhibitor pala yung affected. In type 2 nga lang, qualitative siya. The C1 esterase inhibitor is normal in number but is abnormal in function. So, yan. In this case, C1q is low, pero the mechanism on why is still not understood. So, basta alamin na lang natin ngayon, for now, na mababa daw si C1q sa type 2 pain compared sa type 1. So, that's for your hereditary angioneurotic edema. Next, we also have your hemolytic uremic syndrome. So, I think familiar na kayo dito sa sakit na to. Nung micro, na-discuss ata sa inyo to. Yung particularly sa may Enterobacteriaceae. So, Enterobacteriaceae. So, yan. So, hemolytic uremic syndrome is a disease that occurs due to the fact that these organisms, yung E. coli, O157H7, or under siya sa EHEC, enterohemorrhagic E. coli. So, E. coli O157H7, otherwise known as your enterohemorrhagic E. coli. From the term hemorrhagic, it causes hemorrhage. So, pag meron daw tong mga bacteria na to, particularly also your Shigella, dysenteriae or Shigella, these produce toxins. So kay E. coli, ang toxin niya is Shiga-like toxin. So it is a toxin that resembles the toxin of Shigella. Shiga-like toxin. And of course, your Shigella. So verotoxigenic na mga or verotoxins. Which now cause your hemolytic uremic syndrome. So bakit anong kinalaman ng complement dyan? One of the ways daw on how this one occurs is because of the fact that yung complement natin once na deficient tayo at some complement proteins, yung toxins that are being produced by these bacteria is not really inhibited, no? So nahayaan lang sila. So yung complement should be able to destroy these bacteria. So dapat nasisira nila yung mga bacteria na yan. However, without these complement proteins, I'm not exactly sure of what complement protein yung involved. Pag wala daw yan, yung mga complement na yan, hindi basta-basta masisira itong strain ng E. coli and itong Shigella. Kaya produce ng toxin, ng verotoxin or your Shiga-like toxin, which will cause now your hemolytic uremic syndrome. So, hemolytic uremic syndrome is the most common cause of renal failure in children. This is also characterized by hemolytic anemia. So, dahil dyan nalalas din ang ating red blood cells. Low platelet count because of the fact that not only RBCs are being destroyed, no, but also the platelets. And last is, of course, yung acute renal failure. So these toxins can be damaging to the renal tubular epithelial cells of your kidneys, causing acute renal failure. So for the summary of all the diseases, no, we have your lupus, systemic lupus erythematosus or lupus-like syndrome, tawag daw ni SLE. We also have your recurrent infections. So if there are complement deficiencies daw, then tawag doon, parang yung infections paulit-ulit na nag-occur. So ganun yung case diyan. We also have your Neisseria. We also have your paroxysmal nocturnal hemoglobinuria, atherosclerosis. So pag deficient daw sa C2, parang madali lang ma-deposit yung cholesterol cholesterol substances natin dun sa blood vessel wall, causing your atherosclerosis. Deposition of cholesterol plaques sa blood vessel wall. We also have your glomerulonephritis in the deficiency of C3. We also have your hereditary angioedema, na-discuss din kanina. We also have your pneumococcal diseases. So, diseases caused by Streptococcus pneumoniae. And of course, your sepsis. So, itong mga papasulat ko sa inyo are the ones that are really important because high yield din sila sa board exam. So, for your lupus-like syndrome, the complement deficient there would be your C1, C2, and C4. Take note, walang C3. Ang C3 pwedeng severe recurrent infection or pwede ring glomerulonephritis. So, yan. So, C1, C2, and C4, their deficiencies are associated with lupus-like syndrome or SLE. Systemic lupus erythematosus. Systemic lupus erythematosus. Okay, so proceed tayo sa ano sa Neisseria. So balikan natin. We need the formation of MAC to destroy this gram-negative cocci. Without MAC, mag-occur or magiging recurrent ang ating Neisseria infections. So yun. Next, we also have your PNH. So nag-discuss natin kanina. We have your DAF and MERL. Next, we also have your hereditary angioedema, which is present when there's deficiency of C1 esterase inhibitor. For pneumococcal diseases, so i-highlight ko lang ng onti itong pneumococcal disease. This primarily occur sa mga neonates. Okay? Yung mga pneumococcal disease kasi yun nga, deficiency of NBL and MASP2, which are both important sa defense mechanism of the body of the neonate against the infection during his neonatal years, no? So the mere fact na deficient tong dalawang to, then susceptible yung bata, yung sanggol sa pneumococcal disease. Pati including of course yung sepsis. So deficiency in MBL would lead to neonatal sepsis or pneumonia. Okay, so that's all for my discussion. Are there any questions ba? Hello? Hello? Nandiyan pa ba kayo?